Alrighty, I'm going to go ahead and get started and welcome you all to our Black Medical Anthropologists in Action event. This event is co-sponsored by the Association of Black Anthropologists and the Society for Medical Anthropology. I am joined today by many co-conspirators, but I definitely want to highlight Mika Polanco and Yemar Oyersun, and also Dr. Burton Louie and Karen Williams, who have been really a part of our core team of getting this event to come to fruition today. I also just wanted to say that a lot of this event came out of the desire to just know what Black medical anthropologists are doing. I was a student at WashU in St. Louis, getting my PhD in medical anthropology, and I often had to do a lot of work to find out who was out there. And so I knew about the great late Dr. Leith Mullings, Dr. David Simmons, and then during my early grad school career, I also early grad school / undergrad career, got to meet one of our amazing panelists today, Dr. Liburd. And for me, she was one of the first people to really kind of inspire me to do the work that I now do outside of kind of a traditional medical anthropology space. And so in this world that we're in right now, where we hear words like health disparities and medical racism and abolition medicine and radical public health and reimagining health equity, we really thought it was important to not only center the voices in our community of Black anthropologists, but also really focus on medical anthropology and how a lot of us are really doing important work outside of academia that is really on the pulse of a lot of the issues that I just mentioned. And so my co-moderator this evening is the future Dr. Yemar Oyersun, who will be moderating with me and also helping with the panelist questions. I'm sorry, I didn't introduce myself. My name is Dr. Chelsea Carter, and I am an assistant professor of public health at Yale University. And I'm actually going to pass the baton to Dr. Yemar Oyersun to get us started, introduce herself, and then introduce our fantastic panelist.
Hi, everyone. Thank you, Chelsea, for that introduction and for introducing everyone to this event and its conception. I want to introduce our panelists today, who I'm so excited to have here. So I'll just start. I'm Yemar Oyersun. I'm a graduate student at Rice University, doing my PhD in a cultural anthropology program on how dermatology residents learn to see disease. And like many students, thinking about ways to expand my research and the things that I've learned outside of the academy. And so that's why I'm excited to have all who we have here, including panelists and my wonderful co-host, who may have input here as well, and to have all of you too. So our first panelist is Dr. Michelle Munyikwa, MD, PhD. Dr. Munyikwa is a recent graduate from the Joint MD, PhD program in anthropology at the University of Pennsylvania in 2021. Her current book project, The Spatial Promise of Refuge, explores the relationship between refugee politics and race in the United States of America, centered on the experiences of refugees and asylum seekers in Philadelphia and the institutions designed to care for them. Currently, Dr. Munyikwa is a resident physician in combined internal medicine and pediatrics at Hospital of the University of Pennsylvania and Children's Hospital of Pennsylvania. The next panelist we'll have is Dr. Darius Brittle-Dockery, PhD, MPH, who is a senior experience strategist on PNC Bank's Experience Innovation Team. Dr. Brittle-Dockery is an applied social science researcher with over a decade of expert training and experience conducting ethnographic research and executing research operations with a variety of businesses, nonprofits, and international NGOs. He's a graduate of the Medical Anthropology and Behavioral and Community Health Sciences PhD MPH program at the University of Pittsburgh. Welcome. Our next panelist is Dr. Leandris Liburd, PhD, MPH, MA, who is the acting director for the Centers for Disease Control and Prevention's Office of Health Equity. Among her many roles and accomplishments, one of the most notable is in May of 2020, she assumed the role of Chief Health Equity Officer for CDC's COVID-19 response, which was the first time in the agency's history that this role and function was added to the leadership of the incident management structure during the activation of CDC's Emergency Operations Center. Dr. Liburd holds a Bachelor of Arts degree from the University of Michigan at Ann Arbor, a Master of Public Health and Health Education, Health Behavior from the University of North Carolina at Chapel Hill, and a Doctor of Philosophy degree in Medical Anthropology from Emory University. Thank you for coming, welcome. And our last panelist today is going to be Dr. David Simmons, PhD, who's an associate professor in the Department of Anthropology and Health Promotion, Education, and Behavior at University of South Carolina, a cute image of which we can see in his background, which is exciting for us. I'm a sucker for a good tree. He is the faculty principal of the Galen Health Fellows Living and Learning Community, a transdisciplinary residential environment for undergraduate students pursuing a career in the healthcare profession. Dr. Simmons received his PhD from Michigan State University in 2002 and completed a 3-year National Science Foundation postdoc at Harvard Medical School in the Department of Social Medicine, Program in Infectious Disease and Social Change from 2002 to 2005. Now that we know a little bit about our panelists for today, I'll pass it back to Dr. Carter, who's gonna lead us through some of the questions that we've developed, and then we'll have a Q&A after.
Awesome. Thank you so much for reading all those impressive bios. So we're just going to get started. I feel like, like most ABA events, even though this is co-sponsored by SMA, we're all family here. And so would love for you all to just kind of get us started with telling us a little bit about how you got to where you are today on this meandering path. How did your path from graduate school, all of you have PhDs in anthropology, whether it's cultural or medical, how did that kind of bring you to where you are today? And, just kind of broadly walk us through kind of how do you think that training really supported the work that you all do? And whoever would like to start, I'm not going to dictate that.
I'll go first, Chelsea. Good afternoon or good evening, everybody. Thank you for being here. And I want to thank Chelsea for the invitation to be part of this really important gathering. And I thought I would go first because I think I'm a bit of a wild card here on the panel. Because the way my career started, I was first trained in public health and just about mid-career actually returned to school to pursue the PhD in medical anthropology. And so being in mid-career, I had experienced the limitations, and I say that respectfully, in the theoretical and conceptual orientations of public health and the models that we were using. And then when issues of culture and health started to emerge in my workplace at the Centers for Disease Control and Prevention, I certainly wasn't equipped to bring this focus to my own work and where I was at that time in the division of diabetes translation, where we were focused on diabetes prevention and control. And within that context, I was most interested in exploring obesity as a primary risk factor for diabetes. And at that time, Black women had a higher prevalence of obesity, as well as a higher prevalence of type 2 diabetes. But Black men at that time had a lower prevalence of obesity, but a higher prevalence of diabetes when compared with their white counterparts. And what I was particularly intrigued about was why high socioeconomic status did not protect Black women against obesity, while there was a clear inverse relationship between SES and obesity for white women. So the more highly educated they were, the higher their income, essentially the slimmer they were. Their obesity rates were very, very low. So this really marked like my journey into anthropology, and I was able to go to Emory. And my advisor was Peter Brown. And there was this one article that I don't care, whenever I was looking into research around obesity, he was always cited whenever there were issues of culture and obesity in a public health journal. So I decided, if I could study with him, that would really help me to, understand this dynamic. And so in my training, which was what you would consider an academic model for anthropology, and actually where the word applied was looked upon harshly, like that was not what they did. But I was far enough in my career that it was okay, because I knew I was going to go back to work and I was going to have to take all the things that I learned and somehow incorporate them into the work that we were doing in public health. I walked away from the program gaining far more perspective than I ever would have imagined. And also, it really transformed my views about public health. And so I had to take that into an environment that was and is highly biomedical, very much quantitatively oriented. There was an expression, I don't hear it so much today. People used to say, if you can't count it, it doesn't count. And so, it's all about like the ability to quantify, to draw correlations. And so the qualitative and contextual aspect of the experience of the disease, and even in terms of, obesity, was not something that was really valued. And I can remember, even the language, there are a couple of things that I will always remember. I had a professor at Emory who wrote on my paper one time, she said, "Your writing reads like medical writing." And I thought, I know some people who will be really happy to know that, right? And then I submitted a paper once to a journal, and one of the reviewers said, "You have done a theoretical reading of your data." And I thought, I know some people who would really love to know that somebody thinks what I do is theoretical. And so I think because I had had so much time in public health as well as in the institution, I've been able to, kind of negotiate those two perspectives. And particularly as we have moved forward with health equity and also social determinants of health, and a lot of things that I know in anthropology are debated, contested, lots of, challenges around sort of how we construct and think about those things. But, and the other thing I think with being in an applied setting and being in the government, there are even more things to negotiate. So where I sit today is I'm considered an executive. And so that means I'm really in what you guys would probably think of as administration, but I still have lots of influence conceptually over the work that we are doing. The challenge is bringing a very large institution along. So I'm going to stop right there. And thank you for giving me the time just to share that part of my story. I hope there'll be more that we can talk about over the course of the evening.
Absolutely. Thank you, Dr. Liburd.
I guess I can go next. And again, I want to thank you, Chelsea, and ABA and SMA for putting on this event. And before everybody got on, Chelsea and I were having a conversation, and I think both of us kind of decided that this might be the kind of first gathering of Black medical anthropologists. So kudos to you for bringing us together. And I'm glad that you framed this in the context of a circuitous route, because that certainly is the case with my own experience. At the master's level, I was actually training to be a just straight cultural anthropologist. And at the time I was doing field work in Nigeria, and in this tiny town in Nigeria, in Osun State. And during the course of my field work, despite the fact that I was taking anti-malarials, I actually got malaria. But I didn't only get malaria, I also got dysentery. I had a botfly larva infestation in my wrist. I had a bunch of physical maladies while I was doing field work. And for me, that really kind of conscientized me to kind of the medical issues that people face on the ground. And of course, I had the privilege to leave. I could get medevaced out if I got really sick. But it really caused me to reflect on the types of physical conditions that people face on a daily basis, and got me a lot more interested in medical anthropology. And so when I went on to get my PhD, my focus was medical anthropology. Now, in terms of the kind of applied side, I would definitely consider myself to be a fence straddler. I am at a university, I'm an academic anthropologist, but my applied interests really come from the fact that I was trained by not only medical anthropologists, but also development anthropologists. And so this kind of focus on community development, of working in the community to better outcomes for communities along different measures, be they economic, social, health, et cetera, was very much a part of my graduate school training. The way that that applied kind of aspect developed for me, as I moved on in my education, was really through study abroad and through international education. And for about 16 years, I actually directed a community health program in the Dominican Republic at the Catholic University in Santiago. And this was very much applied work. This was working for the Council on International Educational Exchange, which is an international NGO that provides study abroad opportunities for students all around the world. But for me, it was an opportunity to infuse a public health program with anthropological concepts, and in particular, a focus on things like cultural competence, a focus on intercultural education, and other kinds of anthropological principles. So I definitely consider myself a fence straddler, which is kind of how I prefer it. And that's really kind of my journey towards, this kind of applied, basic approach that I take to my anthropology. And I'll go ahead and end there.
I'm happy to go next. Can you all hear me okay? Sweet. So full disclosure, it is like 80 something degrees in Philadelphia and the windows are wide open. So you may hear the ambient sounds of my neighborhood, which may involve heavy bass, and I apologize for that. So hi, it's great to be here with everyone. And I'm especially grateful to both the ABA and the SMA, two organizations close to my heart, for putting this together and bringing us all together here today. I guess my journey is maybe that I kind of went from medical to anthropological, and then I'm now trying to put the two together, just to say that I have a longstanding interest in anthropology that transpired back when I, maybe as I'm part of the last generation of people to still get like a physical catalog when you went to college with like all the classes in it that you could flip through, a thing they no longer do. And I decided I was going to be an anthropology major because I went through it in my first week or so of orientation and highlighted all the classes I thought would be interesting. And most of them were in the anthro department. And so I made my way over there and did a double major with biology. And through a series of events, ended up deciding I was going to apply to medical school, and never thought I was going to be an anthropologist. And then I got to tell you, there's nothing that makes you feel like anthropology is really necessary like a semester of medical school. There's just all kinds of stuff that happens in those classrooms that is wild. And I took what passed for our cultural competency education at that time, which was only just slightly better than sitting in a room with a list of stereotypes about different kinds of people and their propensity towards authority or their love of church or their addiction to sugar, to really make me feel like I was not necessarily in the right place. And our medical school allows us to take free classes in other departments if you can make the time, which is a big if. And so I said, maybe I should make a little return to anthropology. And I first started in public health, which didn't feel like quite the right fit. And I really, Leandris, it really resonated with me when you were talking about wanting something with a different kind of theoretical background. I had this feeling that if I got an MPH, I wouldn't necessarily be learning a different framework from the one that I was learning in medical school. And I was really hoping to kind of undo some of the things that I was being taught. And so one thing led to another, and I ended up enrolling in the dual MD PhD program to do a PhD in more or less cultural anthropology. I like to think of myself as a cultural anthropologist who happens to work in medical spaces. And from there, I think it has been a really interesting journey. I got towards the end of my MD PhD and was feeling not super excited about medicine. And then of course, COVID happened, and I think really changed what it feels like to do medicine in America and what, physicians think about themselves. Really changed the politics of the hospital in really interesting ways. And it's sort of in the throes of COVID that I started my residency program. I was really interested in doing both adult and pediatric medicine because I'm interested in trauma, and particularly historical and generational trauma, racialized trauma, gender trauma, sexual trauma across the life course. And the approaches to that are really different in pediatrics, where I think we kind of understand children as being at the center of a society. And then something happens when you get to the adult world, and all of a sudden it's all individual choices, behaviors, and faults. And I am interested in what it means to translate across that line and try to affect that. From the applied to theoretical division, I go back and forth about this constantly. I do a lot of work that's collaborative with other physicians that's really interested in what I initially came to anthropology for, which is to sort of undo some of our paradigms about how we think about people and what it means to provide care for them, how we explain the disparities that we see in large population level data, how we explain what it is that we might be doing as physicians to contribute to that. And to that end, I'm really interested in medical education and have done some work specifically on how medical education inculcates early physician trainees with racially laden ideas, whether well-intentioned or not. And then also think about myself as an applied anthropologist, as someone who is teaching trainees in a clinical setting and has the opportunity to help trainees behind me, or even sometimes some of my supervising physicians, understand a clinical set context. Like, explain to me why this patient might have this problem. What is the pathway that might have led them here? What are the social determinants of health, and what are the structural determinants that led them to this point? And how could we be intervening in a more interesting way? That being said, I do a lot of that applied work, but I am like kind of a high theory nerd, and I'm publishing my book with Duke, which probably tells you what kind of book it is, right? And what kind of writing is in it, and how obtuse it probably is. And yet I'm really interested in that. And I like the ability to be able to move between those two spaces and to do things that have more obvious short-term utility, but also be really engaged in work that, fills our intellectual cups, even if we can't necessarily tell what the downstream effects of that thinking will be. And so that to me is some of the beauty of being an anthropologist and having a big tent and having a really big idea of what constitutes anthropology, whether medical or cultural or in between. And with that, I'll stop there, but I'm really glad to be here.
Okay. Hi, everyone. Can you hear me as well? Great. Okay. So also very happy to be here. And first, I want to say thank you to my fellow panelists, the coordinators, the associated organizations here, and everyone else here today. Thank you for joining and listening to us share our stories and our insights. I appreciate the invite and happy to be here, like I said. Now, when it comes to my path, I've had a kind of difficult time explaining this because anybody that sort of knew me in the before times, as I've been calling them, it was a lot of critique of neoliberalism, capitalism as a system across the world, and all of the results that we see today. That was heavy in my work and in my mind, and now I'm a part of a big part of a team that, or my team is a big part of work that's done at one of the biggest banks in the country. And so the turn from not only anthropology and the critique of the very same systems that I'm working in, but also the movement from the medical work that I used to do into now none of that has been interesting for me as much as it is to other people who have asked. And how it all sort of started, there is a sort of through line through what I see as my career thus far, where I found anthropology as an undergraduate, and it just clicked with my brain. I was like, this is sort of how I see the world. Things sorted themselves out in my head a little bit better than when I thought I was going to pursue psych, and I started psychoanalyzing my friends, and like nothing really, it just got more confusing the deeper I got into it. But anthro cleared a lot of that up and challenging things that I was experiencing and enabling me to speak on it in ways that I previously didn't have the language for, the understanding about. And so after undergraduate, I was really trying to prove to myself that people were people, that the anthropological shedding of your ethnocentrism, the relativism actually was the way to go. And I went into the Peace Corps, where during my service, the Arab Spring started and the conflict in Syria started as well. There was an influx of refugees into the village where I was living, and I was significantly affected by that series of events, because when I was leaving the refugee camp there, Zatari had not been winterized, it was just being built. And I was just hearing about the conditions that people were living in. Came back home, I worked for a few years at a startup company that dealt with chronic illness, I guess you would say, or preventative health through online learning. And those things sort of melded in my mind, where I saw a lot of overlap between the conditions that people were in Jordan, and then the conditions that we were addressing through the company that I was working with. And so I actually went into the PhD soon after, as soon as those things sort of melded in my mind, and seeing how external conditions, things that we already know, the social determinants of health, these places and spaces affect people's health in the places and spaces that the refugees that I was living with and amongst at the time were causing health problems. And I saw this as an opportunity to sort of pursue that route, coming in with no real knowledge of where it was going to go. But pursuing the joint MPH PhD in hopes of combining the theory that I saw as a form of truth in anthropology with the practices and the application of public health. The two actually, as we've heard here already, go very well together, in my opinion. Now, I bring all of that up to say, while I was working and pursuing my degree, I had to do an internship at UPMC, which is the regional payer provider system. And I did a number of things there, and then left, went about my way, ended up writing my dissertation, and a woman that I worked with there who was on their design team reached out to me asking me if I wanted to do people research at the bank. And I was like, okay, what does people research at a bank look like? Because I don't know those two worlds. I don't know if they go together all that well, but the description that she gave me really resonated with me. She was talking about how normal people, though they have these big clients, people who are wealthy or institutions that are wealthy, that they do make more wealthy and more powerful. She was bringing it down to the individual level, saying that there were people like my mom or your aunt or grandmother who are trying to just manage their money and take care of their nest egg, whatever that might be, in order to live their lives. And talking about the assumptions and systems that run the bank. And that resonated with the work that I did looking at the humanitarian health system and how it, as a system, as an environment, as a infrastructure, affected people's health. But the structure of those institutions are designed by people with intentions, with assumptions, with ideologies that back them, with ethnocentrisms, these things that we are able to actually look at critically through the anthropological lens. I think anthropology has a unique sensibility at bringing some of these things to the foreground. And I feel like that is what I do day to day at the bank. I would challenge these assumptions. I bring people into spaces where it's generally numbers and data. And I feel like it's necessary in those spaces. And even though I'm not doing medical work, I still feel like I'm very much doing anthropology every day, either through my own corporate ethnography, trying to understand the space, or trying to provide different perspectives for people who typically don't even have a thought towards the human experience that's embedded within these system services and products that they produce at the bank. And so I'll leave it there. And again, thanks for everyone for coming. I'm glad to be here.
Thank you so much to each of you. I think that just really set a great stage of how you all got here. And so now we're going to focus on, what do you do now? I think one of the richest parts of this discussion today is that, I talked a little bit earlier about how I kind of didn't have any examples of applied medical anthropologists. And there's still also very few Black medical anthropologists, period. And so would love you, we read your beautiful bios earlier, but if you all can just give us kind of like, what's your elevator speech? Like in 2 minutes, like, what do you do? What does a day in your life look like? And I'm actually going to ask you to go in reverse order. So we just heard a little bit from Darius. And so you kind of gave us an on-ramp to what you do. So now tell us what you really do.
That's a great question. And still figuring this out. I actually graduated in August, got this job as well at the same time. So it's fairly new to me. And also our department and team. I know there were some people in the chat I saw that were interested in like UX work. We do some UX work, but we've been calling ourselves a human-centered design team that's oriented towards innovation. And so our job is to analyze, let's say, map out, understand the system services or products at the bank and how they affect people's experiences, what pain points they might have, what challenges they run into, what their in an ethnographic sense, what their daily lives are like in relation to whatever we're looking at, in order to eliminate some of those pain points and redesign these things in a way that's either enjoyable, hopefully meaningful and impactful to their lives. So to give a concrete example, one of the projects that I'm working on is looking at a process at the bank, without getting into the details, because the process is like truly boring and it's wretched and everybody hates it. And so that's the reason why we're being brought in, because everybody hates it. We're looking at the process and it's actually internal. So we're talking to employees every day to understand what their daily lives are like in order to then redesign this process to make it actually achieve the goals that they want, have the experiences that they want, because they use this every single day of their lives at their jobs. And so that's kind of what we do. That involves a lot of like meetings, collaboration, joint thinking, which is new to me, to be honest. We work with a lot of interactive software that enables us to like show your thinking, link your thinking to other things, and produce things, deliverables for partners and for other teammates in order to just kind of progress the redesign along. And so that, I would say, could be wrapped up. I call myself at this point a human-centered design researcher. That's kind of what I've been saying, even though my title says something else. But that's the long and short of it, I think.
Goodness, what does my day-to-day look like? It's not really as interesting as what Darius does, but that's okay. Right now, because I'm
the medical doctor.
Yeah, I often tell people that's more like a boring desk job than you would think in this economy. But because I'm a resident physician, I work more than full-time, mostly doing clinical medicine. And a day in my life looks different basically every 2 weeks. Certainly, if anybody who is a participant is interested in doing medical training, I'm happy to get into the weeds about what that looks like. But the long and the short of it is I spend most of my time thinking about how to take care of patients. Since I'm now a senior resident, I'm no longer in my first year. A lot of what I think about too, and what I spend my time doing, is helping to lead teams of people taking care of patients, especially in the inpatient setting. And so that looks like making sure everything gets taken care of, but also thinking about the education and training of fellow doctors who are a little bit behind me. And that's sort of where I think a lot about how to teach in a way that's oriented towards health equity as well. In theory, I also write and give talks at all in my free time, but as you might imagine, that is less free than it used to be. So that's me. Mm-hmm.
All right, so the more applied side of what I do on a day-to-day basis is really as a result of being a faculty principal for a large allied health science living learning community. And so this is a large community of about 400 students who represent bunches of different majors within the health sciences. So we have nursing students, we have cardiovascular technology students, public health, exercise science, biological sciences, et cetera. And so a typical day for me really is about programming events, bringing in outside speakers who are health professionals, either local health professionals or translocal health professionals, bringing them in via Zoom. A lot of what I do is workshops around things like cultural competency, around things like intercultural education, because both of those things are core pillars of the community. I was the inaugural faculty principal for this community. And so I had the opportunity at the beginning of this program to really kind of infuse those anthropological principles, into what at the time was a new living learning community. So lots of boring stuff like, emails and phone calls and, walking across campus to, talk to people and invite them into the community. But basically professional development for these allied health science students, because I know many of them who may be going on to medical school, aren't going to have a more holistic kind of experience and education at that level. So I try to get them while they're undergraduates and introduce holism and cultural competency and some of those anthropological principles to them before they get kind of indoctrinated the other way. But that's kind of me on a daily basis.
So for me, for the last 8 months or so, CDC has been going through a reorganization, lots of changes, and I am essentially leading the reorganization or the establishment of what is now called the Office of Health Equity. So my day is filled with meetings from morning till night, back to back. And they're mostly focused on strategy development. I think one of the big things, in the work that we do versus my studies in anthropology is explaining health problems is only part of what we're held accountable for. We're mainly charged with changing them. And so the big focus of our office is around reducing health disparities and health inequities. How are we going to get that done across a range of population groups that are characterized not just by like race and ethnicity, but also, people with disabilities, LGBTQ plus people who live in rural areas, people who are experiencing homelessness. I mean, you can just imagine those groups that have experienced long-standing health disparities is the focus of our office. And so I spend lots of time trying to change minds about how we do our work, how we can integrate equity into our science, into the surveillance programs and practices. And I also co-chair what's called the Diversity and Inclusion Executive Steering Committee. So I've spent lots of time on promoting diversity, equity, inclusion, accessibility, and what we have added as belonging. I give lots of talks, and up until the pandemic, I did a lot of travel, but the travel it's picking back up. But travel was pretty much suspended. But my travels, I think the last July, I think I went to travel to London to meet with the National Health Service. It's called the Race and Health Observatory. And they were convening a global meeting of about 6 or 7 countries that are essentially grappling with issues of racism and health. So our work is not just domestic, it's also global. And we're grappling with issues of health equity globally and in different contexts. And so, when I really start to talk about what we are doing and what we are called to do, it can be overwhelming. But it's also, very challenging, very exciting. I can't imagine that I would be spending my time doing other than this. But it's a huge lift. The expectations are extraordinary. But that's what a day and a week and like months right now are like for me.
Thank you so much, Dr. Liburd and Dr. Simmons and Dr. Brittle-Dockery and Dr. Munyikwa. Those are all great responses. I'm actually going to go a little off our moderating script because I just, as the anthropologist that I am, there is a theme that keeps connecting each of you all's comments, and the word I keep hearing is applied. And I just want us to have a quick little conversation about it, because when I came up in my training, applied and engaged anthropology was like a dirty word. And I know Darius just came back from the Society for Applied Anthropology conference. Dr. Liburd talked about kind of the mixture of the applied public health and theory work. And you all are really just kind of pushing back without saying it. That applied really isn't as much of a dirty word as I think that big A anthropology makes it seem. And so would love to just kind of hear your thoughts on why is it that it kind of has this connotation within our discipline, and how do we keep pushing back against it?
Yeah, I will say that as a Black anthropologist, I've always been interested in issues that affect the Black community, right? And I think, because of that, because I've been interested in these critiques of power, and discrimination and racism and understanding the mechanics of that, that necessarily has led me towards action. And I do believe that it's really a false dichotomy between applied and basic anthropology. I think that historically it served a purpose to kind of divide them out that way. But for certain populations, certainly, Black folks, other BIPOC folks, I think that's a distinction, that's a dichotomy that hasn't always been so salient for us. Again, given the interest in getting involved in community efforts that better outcomes for the very communities that we come from. So, in part, I believe it's really kind of a false dichotomy. Yeah, I certainly consider myself a fence straddler. Someone who has a foot in the applied world, the so-called applied world, and someone who has their foot in the so-called basic world. But I do believe that you're going to see a blurring, of that kind of perceived boundary in the coming years.
So I'll just say from my time when I was, when I was being trained in anthropology, I think the allure was, again, you get to study a problem, write a book about it, and that's your contribution. There didn't seem to be any accountability in terms of even how many people read the book or if the book impacted anything. So that was the difference. And actually, there's a lot to be said about like having that privilege to study and to write about, and writing being like how you are making your difference. But, again, in the work of public health, as I said earlier, it's not enough to understand the problem. We have to take action on the problem, and we have to be able to document that the action that we're taking is helping to resolve that issue. And I know when I was a student, again, when I was in anthropology, I did not take any classes in the School of Public Health, except for one research methods class, because I knew I was not going to be a good student. I was going to challenge the professor. I was going to say, I know about those. That's not what really happens and what we do. And so anyway, but I just think for my own ability to have a more comprehensive perspective and really to understand better the power of the social context and even the power of history. I mean, some people have accused, public health that I love, but it's been accused of being, ahistorical, atheoretical and decontextualized. And, on a day, we could go along with that. So having this sort of broader perspective, I think, is incredibly helpful. And, it's interesting to me when COVID happened, and you all mentioned that was the first chief health equity officer. When people were observing that it was people of color who were dying at these like rapid rates, and no one, like we were trying to get the data systems together, and like people were dying, and anyway, so there's a lot of push to not only, we need to understand the problem with the data, but we also need to intervene right now and start, like basically we're starting to move lots of resources out into communities and bringing to the table community-based organizations that had relationships. And you saw things, like screenings being set up in churches and all kinds of things where there was this clear sort of mobilization that all of us who have been in this business for any period of time would have told you like 30 years ago, we need to be building that capacity. And there was all of this like, oh my God, what's happening? We didn't know there were these inequities, like what, And so, what I am hopeful is that we won't forget those lessons, but that we'll actually build upon them. And we're in a trajectory right now that looks like that can happen. But anyway, I just think that, COVID, as we like to say, kind of laid bare historical health disparities and health inequities that have existed for decades and centuries, and that are, embedded in systems of, structural racism and other kinds of oppressions. And so even that language that we now are using regularly inside of CDC was uncommon before. So.
Yeah, so I just want to add to that actually. Speaking on the privilege we have to be able to study some of the spaces or some of the topics in the spaces that we've occupied, or to be able to look at our own communities and understand the issues affecting them. I've always found, at least like medical anthropology in particular, to always sort of have an applied bent. It's hard for me to imagine someone drawn to this discipline and have them study, see, experience, connect with people who are experiencing the types of like suffering that we've seen, and understand the systems and the catalysts behind that, and not feel compelled to do something about it. It's hard to just step back and claim objectivity, at least for me. And so I've always felt like even if there was an academic, published book that only addressed, the very heady theoretical things that are in the mix, I always felt like I wanted something attached to my work that impacted the people that I was working with. And so that always led me to NGOs or to some other institution where I could actually, contribute in that space. And the sort of like the wording of applied anthropology being kind of a dirty word, I see it less as applying anthropology in these spaces and sort of like imbuing it within these spaces. So same thing at the CDC, where we're talking about language that we previously were not thinking about in this space is now common terminology. I'm hoping to bring some of the same sort of concepts into the work that I do at the bank, revealing structures of racism, structural violence, et cetera, and how they impact people's work. And so it's less about applying anthropological methods. That still happens and is still extremely important to my work, and then also it sounds like to everyone else's. But also I think just playing off of the last two comments, the idea that we're sort of bringing an anthropological lens into the space rather than and trying to convert people's mindsets in order to have the types of impact that I think we can.
I just want to say I completely agree with everything that everyone said, and I have a couple of thoughts that maybe are slightly different, perhaps. The first is that, I sometimes have this experience where we, when there's something that we write about a lot, that there's a lag time between what we write and say about it in the discourse and what it actually is like, which is to say that on the one hand, I think in a lot of departments, like being applied has a negative connotation, although sometimes I've started to think about that a lot more as sort of like the not quite helplessness, but the sort of like ill-equippedness of many of our educators in graduate departments to help students with applied careers, simply because they do not have like the networks, because they built up a completely different set of skills, right? Because they're training people to do something very different from what they do. Less so sometimes, it depends obviously, than a complete disrespect for the idea that we could be bringing our anthropological ideas out into the world, especially since one of the most common things for us to say as anthropologists is that more people need to think like us in the domains where people can make a difference, right? The other thing that I think about is that, medical anthropology definitely has, I think, more of an applied bent than some of our other subfields, although I think that could be changing. And it's also maybe the most popular, certainly the field in anthropology that is growing the largest. So there must be something happening there that I think, undergrads and master's students look in a wide field of anthropology, are interested in the kinds of questions we answer and how we answer them, and find themselves drawn to that in large numbers, which suggests that I think the future is there. And the other thing that I want to say is someone who maybe kind of is like in the mix and, maybe sometimes wishes I was less, is that a lot of, I think, medical anthropological critique is sort of the kinds of blind spots that happen when you're like doing practice and sort of influenced by the exigencies of every day, right? So that you don't see the unintended consequences of your well-intentioned labor, so that you don't see, how you're missing this entire field. And a lot of what I think medical anthropology brings to the table is that. And so in certain ways, I think that anthropology in its more distanced forms has often offered a lens that it would not have if it was as embroiled as some of these other practice-oriented fields. And there's something to be said for, is there kind of a critical distance that we should be attempting to maintain and institutionalize? Maybe everyone should have enough space and time to actually think about the labor that they're doing. But just thinking about that as someone, who's in an applied field that's like, doesn't actually give you space to think. Sometimes it feels like almost by design.
Yeah, absolutely. Thank you all for going on that tangent journey with me. I really appreciate the responses. To honor time and also honor some of the great questions I'm starting to see in the chat and in the Q&A. This is going to be like our last formal question before we shift over to open questions. But it's kind of a two-part question depending on how you position yourself, but either what do you see that anthropology department can do to better support students that are interested in practicing anthropology degrees, or what did your department do to support you in becoming a practicing anthropologist, and what could departments do to better support students who wish to become this applied anthropology, even if they're not in the medical space, which we kind of see is maybe a bit richer in being open to the applied practicing side?
So I'll just say, when I was at Emory, there was an opportunity to pursue an MPH as well as a PhD. So I think that was one way to give students, exposure. I also think I think to the extent that the faculty can leverage their research that they might be doing in an applied setting or even in a community, and be able to, connect students with community-based organizations or other entities near the university where they can get some, on the ground, experience. When I think about my own training in public health, and I told Tony, he was one of my professors. I think he remembers me, but anyway, we used to have to do things like go to baseball games, and we had to go to church. We had to do all these, I called it hanging out, because I didn't get exactly what the training that because I had just left my undergraduate program. And anyway, I realized certainly much later the influence of anthropology in my training in public health. And it kind of never ever goes away. And so, we had to do field work, which is actually, I think in a lot of public health programs, either has disappeared or it's greatly reduced. And, I hear students, they'll do what's called a practicum, but we had to spend a year in the field. And I spent lots of time in Chatham County, North Carolina. But anyway, I think that there's nothing like having that experience, being able to come back to class and have a discussion with your professor about that. And that requires, connecting across schools or across departments on your campus. I think it's worth it. It's worth that experience.
I will be honest. I think a lot of what departments can do, to encourage to encourage students to do applied anthropology, or students who are interested in applied anthropology. A lot of it, to be honest, I think is actually going to be forced on departments by the market. What I mean by that is, I think given the academic market now, given the jobs that are not available at the academy, I think, I think by necessity, I think a lot of departments are going to have to develop more applied tracks. I know in our Department of Anthropology at the University of South Carolina, we started an internship class, where students can, be engaged in an internship for the course of the semester, they'll get credit for it, etc. Because, honestly, at the PhD level, I think it's unethical to not provide training for your PhD students that is not only for an academic route, if that's what they've identified as the route that they want to take. You also have to give them a diverse skill set, that will allow them to work in the event that they don't get that academic job outside of the academy. So I think a lot of, and you hear my granddaughters yelling in the background, forgive me, downstairs, but I think a lot of this movement towards, more applied approaches within departments, training within departments, is actually going to be forced on departments in the coming years.
Yeah, so I just went through all this transition and was wildly unprepared. Still feel unprepared for the switch that I've made. But what I will say is, similar to Dr. Simmons, that the acceptance of the current state of the job market, at the very least, is going to force departments to at least provide professionalism in a way that isn't only oriented at the academic space. There's a lot of things that you need to prepare for in order to progress forward as an academic. But I think also, just basic skills like task management, how to format a resume, all of these very practical things, even making a website for yourself, would not only benefit academics in a lot of ways, but also if that person wanted to transition to another space, they have a more clear understanding of the transferable skills that they might hold, that also apply to other spaces and places, just as a professional, not just as an academic anthropologist with a capital A. And so I think that sort of acceptance that academia as an institution is competing with other really powerful, big and rich companies that are seeking anthropologists. We're in demand, and I think that's only getting stronger due to the unique sensibility that we bring to these spaces, the way that we think and look at problems, especially those who gain an advanced degree. I think there's a lot of opportunity out there in applied spaces that are public, private, whatever, and that institutions that are training anthropologists have to also train us in some sort of professionalism as well. There's more to say, I'd say. There's like a lot of things that I had to switch up for the again, for the transition, but without getting too granular, I think that's probably like a quick takeaway.
Anything from you, Michelle, before we shift over to some questions?
No, I think they covered it. I'd love to hear some questions.
Okay, awesome. So one of the questions I had was directly about advice, and we have some really great students who have asked some questions. So I'm going to hand it over to Yamar.
Sounds good, thank you. I will direct everyone to the chat. You've been here for long enough that you should be able to scroll up and see there are some announcements also there. I won't say them out loud, but look into that if you're interested in conferences, PhD programs. There are some good announcements there. So the first question I have for you is from Isabella. Isabella asks, how did you choose your higher education program? And did finding a strong, vibrant Black community within these institutions or within the general area play a role in your choice?
Yeah, I'll begin. So the program that we chose at Michigan State was primarily, for two reasons. And I say we because my wife also got a PhD from Michigan State. She was very interested in the African diaspora. And there was an African diaspora research project by Ruth Sims Hamilton that was funded by the Ford Foundation that really drew her attention. In my case, I was interested in African studies, and Michigan State at the time was one of the schools that had one of the top African studies programs in the country. And, of course, it being Michigan, one of the first things that we looked for, to get at this issue of a kind of vibrant Black community was the Black student organization, the Black graduate student organization, which for us was a lifesaver. But we also found ourselves venturing into the community and looking for, community outside of the university as well. And so getting involved in, a Black church, for example, in the community, was something that was important to us. But those are just kind of two brief examples of, that effort to really kind of find that community and build that kind of community to support us in our efforts at a predominantly white institution. So.
Go ahead, Michelle.
Okay, how did I choose my program? I mean, I initially came to Penn for medical school, actually partially because I wanted to be in a city that had a more diverse and vibrant community, which Philadelphia's it, putting a plug in to move to Philly. And I think I was also really wanting to be at a place that had, if, you know, as much as there can be a large community of Black people in medicine or in higher ed, I thought, you know, that Penn did a pretty okay job with that. We have really strong Africana studies here, I think, and wanted to be in a space where there was a lot of community. I got a couple of messages via DM from students who are interested in doing combined MD PhD programs. And so just like as an aside, I would just say that I think it's really important to go to a place where you can be fully funded for that experience and where you're funded with parity along with your colleagues who might be doing their PhDs in more traditional disciplines. And so that's a smaller set of schools that are frankly difficult to get into, but I think financially it's really important to try and find places that telegraph how important they think anthropology and medical anthropology is alongside medicine by financially supporting it in the ways that they would support you if you were a cancer biologist. And that happens to be the case here, and is the reason why I stayed to do my PhD instead of doing it somewhere else. So I think that having a really strong community is important, but I think it's also worth saying that in a lot of places, it's going to be a little bit like strong but mighty, depending on what it is you'd like to do. Small but mighty, I should say.
And I'll just say quickly, as I mentioned earlier, I wanted to study under Peter Brown at Emory, and I was able to do that. But I was already living in Atlanta, so I didn't have to, find a new community somewhere else. And we had, I think, there were 5 Black women in the department at the time. And so I think we developed a very tight network among us. And, there were other Black graduate students on campus, and we all, connected. So it was a good experience in terms of there being, I'm going to call it a critical mass of people of color on campus at that time.
Yeah, thinking back on why I chose my graduate school, partly, to be honest, it was just the combination between medical anthropology and public health being a structured program there, rather than having to piece it together like you might have to at some other institutions. It was structured. I could see the entire program from start to finish. There were people that had gone through it that I was able to speak with before making a decision. But in a similar way, in terms of like a takeaway from my experience, it relates to what Michelle was saying about institutions investing in the medical anthropology or the anthropological track, and that being a demonstration of their actual commitment, sort of like putting your money where your mouth is in a way. The same, I would say, is applicable to the individual. For me, I was given a fellowship once I got accepted that was specifically oriented towards the recruitment and retainment of underrepresented populations at Pitt in particular, and then was also brought in after accepting to be the diversity committee president and work on a post-baccalaureate program called the Hot Metal Bridge Fellowship, which is also oriented at getting people who are typically underrepresented and may not have as strong of a resume to actually apply for graduate programs, but are still interested in anthropology. They can come into the department, study up for a year, strengthen their CVs, get some experience, see whether anthro is even right for them at that point, and then continue on. And those types of commitments institutionally enabled me in a department that was majority white, as many are, but I think I was the only Black scholar there for at least a couple of years until some others came through. But yeah, just that investment and the ability to see that ahead of time, that if I did go there, even if I didn't have a big community in Pittsburgh at the time, I was supported by the department at the very least, and by Pitt even larger than that.
Thank you so much.
Thank you. I didn't see any more formulated questions.
Oh, can you not see the Q&A chat bar?
Oh, no, I can't see the Q&A.
Am I only able to see that? Oh, yikes. Okay, I'm gonna paste them on the document, but I'm gonna go ahead and rattle one off real quick.
Sounds good, thank you.
So, please forgive me if I say your name right, but I think it's Shireen McKinney is one of our guests. She writes, the university I may attend offers MS in applied anthropology. I may take courses to have an med-anth concentration. What PH type courses would make me a strong candidate for domestic or local work? I'm more interested in culturally competent health promotion and behavior change that meets folks where they are.
Well, I think most programs, if you're near, have access to a school of public health within your university, you can certainly take lots of health behavior, health promotion, health education kinds of courses. I think that they're informative. I think it's also always good to have like a grounding in epidemiology and biostatistics if you can do two. But in terms of I think any course that might be offered that would look at issues associated with culture and health, definitely I would take those as well.
Yeah, I want to just echo what Leandris was saying. I think courses in, evaluation, courses, in monitoring, as well, as Leandris said, courses in epidemiology. I mean, having a basic understanding of epidemiology, biostatistics, I think would serve you really well, as those have really kind of, transferable skill sets. Any of those classes, I think would, be a benefit for you.
I'm going to chime in very quickly. I think everything that's been said is right on point. But as the question was coming across, I'm usually the only anthropologist or public health person in the room. And so I was like, oh, got to gear up for this question and think through it. But then I forgot we're all medical anthropologists here, and then that everybody has an understanding and the insight into this. So I'd agree with everything that's been said, and also throw in community-based participatory research classes. If you can get out there actually and get credit for it, that's that's the golden ticket in terms of classes.
Thank you. I'm going to direct these questions to different people, but I'm going to start with a question from Ariana Avila, who asks, as anthropology students and professionals, did you receive any resources, mentorships, or support to pursue a career outside of academia? And if not, what did you do to create those networks? And I think maybe Dr. Brittle-Dockery and Dr. Liburd would be good people to answer this question especially.
Well, I mean, my answer is fast, and then I'll hand it over because I already had a job. I was saying I was like mid-career when I came back to pursue the degree in medical anthropology. So I already had a job. But you know, the Emory program was so well resourced that if you were there, I mean, there's so many opportunities. You know, like I said, you could have pursued an MPH at the same time as you're doing the PhD, that, you know, it would have been paid for as well. And also, you know, I think the faculty there also had lots of ties to particularly CDC, but I would, you know, encourage you again, as much as possible to get kind of on the ground community experiences while you are in your training, because that creates a base of reality from which you can then, you know, kind of test, if you will, those perspectives that you're being taught.
Yeah, I'd agree wholeheartedly there. And I'd say in terms of mentorship, I was blessed with a number of mentors because I was in between programs and doing things that some of the people within each department weren't doing. So I had to seek things and people out, seek courses out in other departments, which expanded my network because you're just organically meeting people and being taught by them or collaborating with them on projects or just in the classroom. That was also helpful. And something to kind of put that in perspective, a friend of mine at a point where I was sort of frustrated with you know, I always saw in my mind like mentorship being someone that I regularly went to progressively build on like this professional or at that point my my academic track and sort of evolve and be invested in my success. And though there were people along the way that were, I don't think anybody could completely be my mentor because no one had gone down the same path that I was sort of going down at the time in the places where I was. And so a friend of mine asked, are you getting what you need, or is it just hard to get and you're frustrated? And I'd say, you know, I had to answer like I was getting what I needed, but I had to go to different places to get it, especially if you're going outside of the academic track. Like maybe some people in your department have no idea how to actually advise you. And so I would recommend reaching out to people that are doing anything that you're interested in before you need a job and just asking them if they'd be willing to speak with you about it, get a sense of it in a similar way that Dr. Liburd just spoke on, getting a sense of the reality that you can sort of step on and step off of as your foundation into these spaces is probably the best thing. And I'd recommend at the very least, like informational interviews to start. Networking isn't bad. It's another dirty word in some places, but that'd be my suggestion, is that if you network without the intention of saying like, here, give me a job, or I need something from you, I think people have been, or I don't think I know that people have been more than willing to speak to me about those things. And I'm sure that would continue to be the case for anybody reaching out via LinkedIn or any other platform like that.
Okay, thank you so much. We have time. We really don't have time, but we're trying to make time, if you don't mind, for one more question. And then we also want to open the floor to Dr. Whitehead, who wanted to give a comment as well. So I'll ask this last question to Dr. Simmons and Dr. Munyikwa. It's from Devin Brown, who asks, what makes your medical anthropology training or in education indispensable in your applied work? Without it, for example, which important tools would be missing from your toolbox as a professional?
Yeah, that's such a tough question, because I feel like my toolkit, more than being, kind of medical, is more fundamentally anthropological, in terms of, again, the attention to holism, the attention to looking at health problems from multiple perspectives, in terms of my approach to, again, intercultural education, cultural competency. It's difficult for me to really kind of distill out kind of the purely medical, side of that equation, because again, so much of it is more fundamentally based on anthropological principles. But maybe Michelle, being an MD as well, could speak to that more.
Yeah, I mean, I was trying to think about that. It's hard to describe anything I do as indispensable, but if, let's say that it is, for sake of argument, I think that, I think that honestly, as time goes on and more undergrads and medical students are coming to the table with a different kind of social awareness, it's less unique to, be thinking at all about the social determinants of health as a physician, right? Like, many of my colleagues think about those questions. I think sometimes as anthropologists, we don't give doctors enough credit for that. But I think that what is missing is the ability to really tease something out in its downstream complexity, in ways that, involve social systems, historical processes, et cetera, that are far bigger than ourselves and our own generation, right? I think being able to tell that, poverty is not equally distributed and certain health conditions are not equally distributed, I think is almost like table stakes for many people at this point. But it's that, ability to say, this is complicated, but it's still my business and it's still my job to try and figure it out. And I have the tools to do so, and I don't feel overwhelmed by it, I think is the main difference. And it would be my hope, as I've already seen over the course of the, 12 years or so that I've been doing this, that would be less and less necessary over time. Like I hope to feel like I have no job to do, by the end of my career. And honestly, the med students I teach first year med students all the time, are so different now, even than when I first started teaching them 10 years ago. Like, the kinds of questions they ask, the things that they know, the stuff they're concerned with, the ways they push me, so I think that is becoming less and less unique, but that's sort of what I would say.
Thank you so much. And I bet, at least in my experience, the identities of those students has changed in the last 10 years as well. We are over time, but we like to keep our promises here at the SMA and ABA. So we'll give Dr. Whitehead 2 minutes to comment on something he brought up earlier. And then we will need to wrap up. 1 second. I'm trying to unmute you. Okay, we should be able to hear you.
Yeah,
Okay.
The discussion earlier about what do you do now? And I think someone mentioned something that I've been thinking about for a long time. I love my discipline. I had a hard time getting the PhD. I'm not going to go into that. But after spending 11 and a half years on the faculty of the School of Public Health, the University of North Carolina, I learned some things that when I came back to anthropology as chair of the department at Maryland, there were some disciplinary cultural differences. And I remember about 20 years ago, I got the sense, and I haven't moved from that anthropology programs, particularly for cultural anthropologists, was like a new version of the miseducation of the Negro. Because what I saw departments doing, they were socializing people into thinking that the only thing they could do with the degree was to teach anthropology in anthropology departments. And those jobs were scarce. I remember sometimes in the early 80s, only about 25% of people with PhDs in anthropology were actually teaching in anthropology departments. So my whole orientation is, how do you make anthropology work for you? And so some of the discussion earlier about how you use it. And I was always shocked with how, once I came back to anthropology, even some anthropologists working in those professional spaces were afraid to say to people that they were trained anthropologists. I didn't understand that. For me to say I'm not an anthropologist is like saying I'm not Black, but I couldn't get away with that. And so I listened to a lot of people say that, but for me, it was always a thing to let people know. So most of my consulting in public health or elsewhere, I say up front, I'm an anthropologist and you need me. Any particular discipline or profession that has to do with humans, they could use an anthropologist, but that person has to be well-trained because, and so public health, medicine, and all of the allied professional areas, they allow more training with regards to anthropologists, because I was in a department that was community focused, community action, change. And so they knew that they needed to have anthropologists, other disciplines, and Black folk to be somewhere in that mix. Anthropology departments are still mostly white because they study these communities, not necessarily work for the betterment of those communities. So I'm going to stop.
Thank you. Yes, thank you so much. I think those are excellent comments to wrap up what we've been talking about, and really give us a perspective into these issues have been around for a long time. So any last words from anyone on the panel before we head out? This recording is going to be on the ABA's YouTube channel. And so if you missed a part of it, or if you want to review a part of it, that should be available to you later on.
So I'd just like to say in closing that I am so glad to know that there's a generation coming behind me. You all inspire me. I'm encouraged. I know that when I hand off the mantle, I'm going to be putting it in good hands. And so thank you for taking the time tonight just to hear our stories and our perspectives and opinions. And we're rooting for you. You're going to make it happen.
Any other final words before I give a final word? Alrighty, well, thank you so much to Drs. Liburd, Munyikwa, Brittle-Dockery, and Simmons for being here with us today, sharing your stories, inspiring the next generation of Black medical anthropologists, and just showing up as your full authentic selves. We've gotten so many beautiful comments in the chat if you guys didn't get a chance to look at them, but we might have to cook up a part 2 coming soon. So be on the lookout. But thank you for your time and talents and, just showing up for ABA and SMA. And thank you to all of the participants for being here today. All righty. Thank you all.